All right. Good morning, everybody. Hopefully you are all having a great start to your Tuesday. Here in Sioux Falls, it is snowing, which I was not expecting. So it's a little chilly here. But anyways, we are happy to get together for our Spring Tobacco Control Institute of 2022. I'm Hillary Larson with the South Dakota Tobacco Control Program. And I will be your MC throughout the Institute this year. We are, always bummed that we can't get together in person, but fingers crossed next year we will be able to. But we are happy that we at least have the technology that allows us to still get together and have some great conversations. So we are going to make today and tomorrow as, feel as in person as possible with different breakout rooms and different things like that. So we do ask that you participate and try to utilize all of the interactive features that we have planned. And as far as, I just lost my train of thought, but as far as we go forward today, we will have some housekeeping rules that I'm going to go over here on the next slide. Be sure to mute your audio. And we do have everyone muted right now, and we have everyone with their cameras off just to help with the functions of Zoom. But when we get into breakout rooms throughout different times of the Institute, you may be asked to, turn your camera on. And so it kind of helps with engaging discussion a little bit more. You can ask questions at any time in the chat box, and we'll try to get answers to you as soon as we can. And just know, because we are virtual, we do understand there's, always other things going on. If you need to step away to take a phone call or use the restroom or just grab a drink of water, that is okay. Just when you are present, to stay as present as possible. And just a quick reminder that the Institute can be counted for continuing education credits. So in your registration, you marked if you needed a certificate of attendance, which we will get to you. If you forgot to mark that you needed one and you do need one, just email me and we will add you to that list to make sure that you get a certificate. And finally, the Institute is being recorded and will be made available later on. So we will keep you posted on when that is ready to go. Just a quick note before we start, we want to acknowledge the spiritual and ceremonial value that tobacco has in American Indian culture throughout the day today and tomorrow. So tobacco refers to commercially produced tobacco products only. And as far as muting, I know we've been using Zoom for a few years now, but sometimes some of us don't use Zoom as often. So just wanted to go over some of the basics here quick. To mute, if you hover over the left bottom corner, there should be a mic, and that's where you can mute and unmute yourself. Next to that is a video. So that's where you can start and stop your video when you get into breakout rooms. It is important to rename yourself if you are not showing up as your correct name. You can go to the participant list and hover over your name, go to more and ask to rename yourself. The reason this is important is because we are entering everyone in who attends for prizes, door prizes, I guess you could say, even though we're not in person. And so by participating in the different activities, you will be entered into that drawing to win a prize. And then there is the Annotate feature where if you hover over the top of your screen, you should see you are viewing Alexis Bailey's screen, or it may say Sarah Anderson Fiore. And then under View Options is an Annotate button. The one disclaimer here is there are a few organizations that their Zoom may not allow you to do Annotate. And so if that does happen, feel free to still participate by just entering your answers into the chat. And we will still count that because we know that doesn't always work. And then there's reactions. So on that bottom bar there, you can go to reactions. So, throughout speakers or after speakers, you can always react by giving them applause, a little celebration, anything like that. Next, there is the participation or participant guide, which I emailed out yesterday with the final reminder. It's also in your calendar hold for today. And Sarah, I believe, is going to put it in the chat as well for you to download if you would like that. Really, this guide is kind of where all your answers are at regarding some of the logistics of the Institute. So within there is the links for Zoom, how to do different things in Zoom, but also information about our speakers, areas that you can take notes in about each session, and then also some of the wrap up details. So if you're wondering about, how do I do the evaluation, or how do I get a certificate of attendance if I forgot to ask for one, all those details are in this guide as well, along with more information regarding how to earn points for the door prizes. Technical issues. If you are on before 9, you witnessed that we've already had our first technical issue today. So let's hope that we got it out of the way and we're good to go now. But we all bear with each other, as technology isn't always our friend, but we do appreciate that it provides us these opportunities at the same time. If you would have any issues, feel free to email Natalasia with Emery. She is kind of our person on the back end running everything and making sure that everyone is not having any issues or helping them fix the issues. So once again, I've mentioned prizes multiple times already this morning, but we did do a welcome trivia before 9. So anyone that participated in that got points towards the prizes that we're drawing for, and also just by being here in attendance. So keep that in mind as we go forward throughout the next 2 days. So today's agenda, we have quite a packed agenda for the next 2 days, but I am super excited about the sessions we have. I think you are all really going to enjoy them. So we will start with our keynote at 9:15. We do have 2 breaks scheduled today, and then our last session will end around 1 p.m. Central Time. If you, I do know that we are going a little bit over some individuals' lunch hours, so feel free to, eat while listening to a session, or if you just need to have a snack, any of those are okay. So we are a little ahead of ourselves, but I think we are okay. I will introduce our keynote here. Henraya, are you okay?
Yes, thank you.
Okay.
Can you hear me?
I can. Perfect. All right. So now I'd like to kick off our keynote session, Tobacco Prevention and Control in the United States, where we've been, where we are, and where we're headed. Today's opening session will discuss patterns of tobacco use in the United States, the negative effect of tobacco use, and proven and emerging strategies to promote cessation. I am very excited to introduce our keynote speaker, Dr. Henraya McGruder. Dr. McGruder is a senior research scientist and project officer in the Office on Smoking and Health, CDC, and a lieutenant commander in the United States Public Health Services. Dr. McGruder has been at CDC since 2002 and began her career there as an epidemic intelligence service officer. Her main tasks at CDC is to monitor and track performance on tobacco control indicators for states in Illinois, Minnesota, Wisconsin, South Dakota, and North Dakota. She is a subject matter expert in tobacco cessation, mainly via telephone quitlines and health disparities. Dr. McGruder holds a bachelor's degree in psychology from Hampton University and a master's and PhD in neuropsychology from Howard University. Please join me in welcoming Dr. McGruder and give her a virtual round of applause.
Good morning, everyone. Thank you, Hillary, for your opening remarks. And thank you for the invitation to speak at the South Dakota Institute and for organizing such a summit. I am so very happy to be here with you today. As you heard, I started my journey at CDC in 2002, working in heart disease and stroke. While there, I learned quite a bit about chronic diseases and how many of them have the same risk factors. I also became truly passionate about researching and publishing the many health-related disparities among persons with chronic diseases. One of the last projects I worked on before transitioning from heart disease was the Paul Coverdale National Acute Stroke Registry, where we compiled stroke data from a variety of states as a way to track national trends. My work on this project was the springboard into commercial tobacco control. 2 years later, I was asked to manage the National Quitline Data Warehouse, which I know some of you may know. This project had similar data dissemination goals as the Paul Coverdale National Acute Stroke Registry. While working in tobacco control, it was made clear that commercial tobacco cessation and prevention of initiation can have exponential impacts on the overall health status of Americans. Oprah once said, "Let passion drive your profession." I have been so fortunate to have this play out in my life so that I can be a part of the great work of South Dakota. Since November 2019, I have been the public health advisor for South Dakota and have been thrilled to be a part of the great work done here. Stewardship of the national and state tobacco control program executed via cooperative agreement has been a very rewarding experience. Next slide. I am an employee of the US government, and the findings and conclusions in this report are mine and do not necessarily represent the official position of the CDC. Also, use of brand names in this presentation do not imply any official endorsement. And finally, I have no conflicts of interest to disclose. Next slide. My goal for everyone here is that each of you will be able to walk away from this presentation armed with tools to better educate yourself and others. This includes listing the negative effects of tobacco product use, describing key patterns and trends in tobacco product use in the United States, discussing the benefits of quitting tobacco products, and describing evidence-based strategies to prevent and control tobacco product use. Health equity is central to our work at the Office on Smoking and Health. So I want to start with a couple of clarifying statements and definitions that I will be using throughout today's presentation. The focus of my presentation is on commercial tobacco, as was presented earlier when Hillary did her introductory slides, and not the sacred and traditional use of tobacco by some American Indian communities. Also, when I describe a health disparity, I am referring to differences in health outcomes and their determinants between segments of the population, as defined by social, demographic, environmental, and geographic attributes that can result from unjust and/or unfair distribution of resources, power, opportunities, and environmental conditions. Health equity is the attainment of the highest level of health for all people. Now, equality is not the same as equity. Equality is about sameness and uniformity of conditions and distributions of and access to resources and opportunity, while equity is about fairness and specifically fair conditions and distributions of and access to resources and opportunities based on need. So let's start with why tobacco use is a public health priority. Next slide. Tobacco control has been a public health priority since 1964, when the first Surgeon General's report was released stating that cigarette smoking causes lung cancer in men. Now, more than 50 years later, we know much more about the impact of smoking on health. Therefore, tobacco use continues to be the leading cause of preventable death and disease in the United States. Cigarette smoking causes more than 480,000 deaths annually. For every American who dies of smoking, at least 30 are living with a serious smoking-related illness. And cigarette smoking is costly. Each year, cigarette smoke costs more than $300 billion in medical costs and lost productivity. Since the original report in 1964, there have been 34 Surgeon General reports on commercial tobacco control, each adding to our broad base of science. This year, we are expecting to issue our 35th SGR, as it's called, on tobacco and disparities. We are also working on an SGR on tobacco and behavioral health, which we expect to release in 2023. No tobacco product use is safe. Cigarette smoking harms nearly every organ in the body, causing 12 types of cancers, major chronic diseases like heart disease, stroke, lung diseases, and type 2 diabetes, amongst others. Smoking doesn't just impact the person who smokes. Exposure to secondhand smoke, even for a short time, can be harmful. In children, it can cause respiratory illness and sudden infant death syndrome. For adults, secondhand smoke contributes to lung cancer, heart disease, and strokes. There is no safe level of secondhand smoke exposure. Next slide. I would be remiss if I did not briefly mention COVID-19. Being a current or former cigarette smoker can make a person more likely to get sick from COVID-19. One of the best things a person can do is to quit smoking to reduce their risk of serious illness. The good news is that cigarette smoking has declined over the last 50 years. Among adults depicted in the blue line, cigarette smoking declined from about 25% in 1997 to 14% in 2019. Among high school students depicted in the orange line, about 36% reported smoking cigarettes in 1997 compared to nearly 6% in 2019. The bad news is that the tobacco landscape is constantly evolving, which is of great concern, especially to our nation's youth and those populations for which health disparities exist, and they are remarkably high. Let's review both of these issues in more detail or depth. Let's start with e-cigarettes in our nation's youth. The landscape of commercial tobacco products continues to rapidly change to include an array of combustible and non-combustible, non-combustible, and electronic products. Just as combustible tobacco products have evolved to include cigarettes, cigars, cigarillos, little cigars, and hookah, e-cigarette products include a variety of types with diversity in shape, size, and flavors. There continues to be new products introduced to the market. For instance, new products that claim to be made from synthetic nicotine are now being marketed. Although we do not know yet the impact of these products on health, the fiscal year 22 appropriations bill that is tied directly to CDC's funding was just signed by the president and gives FDA's Center for Tobacco Products the authority to regulate synthetic nicotine. Next slide. E-cigarettes were first introduced into the US market around 2007. There are 3 types of e-cigarettes in the US market. The first type are disposables. These products come pre-filled and are not intended to be refilled. They may or may not be used multiple times before being discarded. They can look like manufactured cigarettes or have other shapes. Examples of this include the puff bar. Refillable e-cigarettes are the second major type. These typically have a tank or chamber that the user fills with e-liquid that can be purchased or made. These are sometimes called tanks, vape pens, or mods due to the shape and the reality that they can be modified by the user. E-cigarettes with cartridges or pods are the third type. These are intended to be reused with a separately purchased pod, which is discarded after use. Examples of this type include Juul or Surin. The science surrounding e-cigarettes continues to emerge. However, let's talk about a few reasons as to why we are concerned about them. First, e-cigarettes threatens to reverse the progress we have made in reducing tobacco use among youth. In a 2018 advisory, the Surgeon General declared e-cigarette use among youth and young adults an epidemic. 2021 data shows that 13.4%, or 2 million of the nation's high schoolers, reported current use of tobacco products. As you can see, e-cigarettes are by far the leading tobacco product used by high school students at 11.3%, or 1.7 million high school students. Another reason for concern is that nicotine exposure during adolescence poses unique dangers to youth. Most e-cigarette products sold contain nicotine, which is highly addictive. Nicotine can harm the developing brain, as the brain keeps developing until about age 25. Using nicotine in adolescence can harm the parts of the brain that control their ability to pay attention, how they learn, their mood, and impulse control. Additionally, according to the U.S. Surgeon General, using nicotine in adolescence may also increase the risk of future addiction to other drugs. There are multiple factors that contribute to youth starting to use tobacco products, including e-cigarettes. Many of these factors are described in the 2016 U.S. Surgeon General's report on e-cigarette use among youth and young adults. There are three main factors that contribute to youth e-cigarette use: advertising, flavors, and nicotine. Let's look at each one of these in detail. First up, advertising. 70.3%, or more than 17 million of the youth, have been exposed to some form of e-cigarette marketing. Among students who used social media during the period of time that was observed, 70.3% reported seeing an e-cigarette related content. Next slide. Next, flavors. In 2021, more than 8 in 10 middle and high school students, nearly 1.7 million of our nation's youth who currently used e-cigarettes, reported using a flavored product in the past 30 days. Broken down by school type, that is 85.8% of high schoolers who currently used e-cigarettes and 79.2% of middle schoolers who currently used e-cigarettes. Among middle and high school students who currently used flavored e-cigarettes, the most common flavor types were fruit, candy desserts and sweets, and mint, which is considered a flavor, and menthol, which is considered a flavor plus a cooling sensation. The last point I want to make regarding youth and use of e-cigarettes is related to nicotine salts. Many e-cigarette products now use a type of nicotine called nicotine salts. Regular cigarettes and some e-cigarettes use free-base nicotine, which has a high pH and is very alkaline. This results in a harsh feeling in the throat. By using nicotine salts, manufacturers have lowered the pH of the nicotine and reduced this harshness. This allows the user to more easily inhale very high levels of nicotine. This is concerning for youth and young adults in particular, since it means that higher levels of nicotine can be ingested more easily, which increases the likelihood of developing addiction. It is important to acknowledge that as the science surrounding the use of e-cigarettes continues to emerge, we recognize that their use can pose potential benefits and potential harms. The use of e-cigarettes is unsafe for kids, teens, young adults, pregnant women, as well as adults who do not currently use tobacco products. E-cigarettes have a potential to benefit adults who smoked, who are not pregnant, if used as a complete substitute for regular cigarettes and other smoked tobacco products. For e-cigarettes to have a net public health benefit, those benefits would have to outweigh the risks. Moreover, any potential benefit that e-cigarettes may have among adults who smoke and use them to quit completely should not come at the expense of a marked increase in use among youth and young adults. when it comes to e-cigarette use for cessation among adults, the evidence is limited and the research is still ongoing. There is currently insufficient evidence to say that e-cigarettes in general are an effective aid for smoking cessation. It is also important to note that e-cigarettes are not currently approved by the FDA as a quit smoking aid. Let's switch gears now and talk about health inequities and their impact on the tobacco-related health disparities. Social and structural inequities affect tobacco product-related health and health outcomes. The existence of these disparities is rooted in inequitable distribution of resources, opportunity, or conditions for population groups based on their race, ethnicity, gender, sexual orientation, socioeconomic status, geographic location, and zip code. If they have a behavioral health condition, and so many other characteristics. Next slide. Inequitable policies and practices have important implications for health and health outcomes related to commercial tobacco. There are a number of historical examples, but some include the institution of slavery forcing Black people to grow and harvest tobacco, policies leading to loss of land, languages, and traditional practices, such as those about the use of traditional tobacco among American Indians and Alaska Natives, redistricting and practices related to urban planning, which have economic implications and impact how tobacco is sold, marketed, and advertised. So let's look at some contemporary examples of drivers that have shaped disparities in commercial tobacco use, secondhand smoke exposure, and quitting. A just society ensures that no person, regardless of age, race, ethnicity, income, or place of residence, is exposed again and again to experiences that we know are harmful. Yet in some communities, there is a constant flow of advertising, discounts, and displays of commercial tobacco products, channeling more of these dangerous products and the health problems that come with them into the very places that have the fewest resources to deal with them. Some communities are bombarded with tobacco ads, and some social groups are targeted with tailored advertisement. Discounts and special sales in communities of color keep products cheap and visible, and tobacco brands use cultural events to make themselves seem like part of the group's lifestyle. Some examples are the tobacco industry tailors marketing to young rural men by advertising chewing or dipping tobacco with imagery of rugged individualism. Ads depicting cowboys, hunters, or race car drivers are carefully placed in retail areas most likely to reach young rural men. Historically, tobacco industry product promotions of American Indian Alaska Natives featured symbols and names with special meanings to this group. For example, the American Spirit cigarettes were promoted as natural cigarettes, and their packaging featured an American Indian smoking a pipe. Next slide. The second driver is uneven protections from secondhand smoke exposure for some population groups. South Dakota has a comprehensive smoke-free air law which bans commercial tobacco use in private work sites, restaurants, and bars. Smoke-free air policies are critical public health measures, keeping deadly chemicals out of the air we breathe. Unfortunately, these protections aren't equitably applied and evenly available to everyone, leaving some groups at higher risk of secondhand smoke exposure than others. Inequalities linked to class, race, ethnicity, gender, occupation, and sexual orientation are also linked to disparities in secondhand smoke exposure. Some examples are income inequity is linked to unequal exposure to secondhand smoke. People who rent in apartment complexes that allow smoking are exposed to more secondhand smoke than people who live in a detached home because smoke travels through buildings' air ducts. State smoke-free laws do not automatically cover sovereign tribal nations or reservations and many native jurisdictions. As such, more progress is needed to ensure smoke-free policies, which respect the difference between traditional and commercial tobacco, are needed in many American Indian communities, including in casinos. The third driver is inequitable practices in access to healthcare and treatment. Referrals to treatment, access to treatment, and the ability to receive the highest standard of treatment for tobacco-related health issues varies widely. The majority of people who smoke want to quit, and more than half of them try to do so every year. Proven treatments make it more likely that people will quit smoking for good. Yet inequities related to healthcare and treatment are evident, and certain population groups encounter barriers to treatment for tobacco product use and dependence. Some examples are research comparing the experiences of non-Hispanic whites and Hispanic patients have shown that Hispanic patients are less likely to be asked about tobacco product use by their healthcare providers, and they are less likely to get advice about how to quit. Even though people with mental health conditions have a high prevalence of commercial tobacco use, only 1 in 4 mental health treatment facilities offer tobacco cessation services. As previously mentioned, when I spoke about youth e-cigarette use, flavored products are also a driver of tobacco product use by youth and young adults. Tobacco companies use flavors to entice people to try their harmful products. Flavors improve the taste and mask the harshness of tobacco products, making tobacco feel easier to inhale and potentially easier to start and keep using. Let's look at a specific menthol example. Tobacco companies add menthol to make cigarettes seem less harsh and more appealing to people who are new to smoking and young people. Tobacco products with menthol can also be addictive and harder to quit. Tobacco companies target marketing of menthol cigarettes to people by using themes and images that have appealed to specific audiences. For example, there is heavy marketing by tobacco companies in neighborhoods with more African American residents, magazines that are popular with African Americans, and at music and lifestyle events aimed at African American people. Tobacco companies also target menthol cigarette marketing to people who are new to smoking, mostly young people, using themes and images that appeal to these groups, like popularity, being accepted by people in their age group, and positive self-image. Social determinants of health are conditions in the environment in which people live, work, play, worship, and age that health outcomes. The air we breathe, the education we receive, income and economic stability, our neighborhoods, our environments, access to health and healthcare, and the larger social and community context are all part of the broad picture in which we live that plays a part in determining our ability to live a healthy life. Addressing social determinants of health is the pathway to helping all populations have their just opportunities to achieve their highest health potential. And achieving health equity has been and continues to be a long, hard journey, but it's one that also requires dedicated effort and action through meaningful partnerships and collaboration. So now that we've looked at the drivers of tobacco-related health disparities, let's take a detailed look at groups disproportionately impacted by tobacco. Of all racial and ethnic groups, American Indians and Alaska Natives have the highest prevalence of cigarette smoking in the United States. New data from the National Health Interview Survey released last week showed that in 2020, Current cigarette smoking among adults ranged from 27.1% in American Indians, Alaska Natives to 8% among Asians, non-Hispanic Asians, and Hispanics. There are also marked disparities in cigarette smoking by race, ethnicity, education level, disability status, and sexual orientation. Among US youth, next slide. Among US youth, a similar proportion of male and female students in middle and high school reported current use of tobacco products. However, similar to what we see among adults, disparities in use exist by sexual orientation and race ethnicity. Among both middle school and high school students, use of any tobacco product is higher among youth identifying as lesbian, gay, or bisexual compared to those identifying as heterosexual. There are disparities in secondhand smoke exposure by age, race and ethnicity, poverty level, and education. Children aged 3 to 11 are more likely to be exposed to secondhand smoke than adults, and non-Hispanic Black people are more likely to be exposed than non-Hispanic white or Mexican American people. Individuals having an income below the poverty line and having an education less than a high school diploma are also more likely to be exposed to secondhand smoke. There are also socioeconomic and racial ethnic disparities in cessation. Non-Hispanic Asian adults are more likely to make a quit attempt than any other group. Adults with private insurance are more likely to receive clinical advice than adults who are uninsured. Adults with private insurance are more likely to have successful quit attempts than those with Medicaid or who are uninsured. And non-Hispanic white adults are more likely to use evidence-based treatment, such as counseling or medication, than non-Hispanic Black, non-Hispanic Asian, or Hispanic adults. So let's switch gears now and talk about what we can do to prevent and control commercial tobacco use. In the year 2000, Surgeon General David Satcher acknowledged a recurring theme that is still relevant to the tobacco control movement today. He said, "Our lack of greater progress in tobacco control is more the result of failure to implement proven strategies than it is the lack of knowledge about what to do." Knowledge about what to do. Many of you may be nodding your head right now. In the 22 years since the Surgeon General said this quote, we have implemented our knowledge to great success. There is still more to be done, but let's review what we know works. Population-based prevention measures are proven to reduce tobacco use and tobacco-related morbidity and mortality. These include increases in tobacco prices, smoke-free policies, cessation access, and hard-hitting media campaigns. Although many factors affect the final price of cigarettes and other tobacco products, the most important policy-related determinant of tobacco prices is excise tax. A 10% increase can lower the amount people smoke by up to 5%. Strong evidence shows that increasing the price of tobacco products is effective in reducing tobacco use and preventing initiation of tobacco use by youth. It also prevents relapse among people who have quit. Evidence also shows that increasing the price of tobacco products can reduce tobacco-related disparities among people in different income groups and may reduce disparities among different racial and ethnic groups. Studies have shown that sensitivity to tobacco prices is highest among Hispanic people, followed by African American and white people, regardless of differences in income. People who smoke and have low income or certain lower income occupational groups and youth are also more responsive to price increases. So let's take South Dakota, for example. The current excise tax in South Dakota is $1.53 per pack. On the map you see on the slide, the states represented by the darker colors have lower excise taxes, while the states represented in the lighter colors have higher excise taxes on cigarettes. Through December 31st, 2021, the state excise tax on cigarettes ranges from 17 cents per pack in Missouri to $4.35 per pack in Connecticut and New York. The federal tax remains at $1.01 per pack. Next slide. I know that was a lot to digest. Eliminating smoking in all indoor spaces is the only way to fully protect non-smokers from exposure to secondhand smoke. Smoke-free policies are the most effective way to provide protection from exposure to secondhand smoke. Equitable adoption and enforcement of these policies throughout the U.S. would help alleviate health disparities resulting from secondhand smoke exposure. Currently, 27 states, 4 territories, and the District of Columbia have implemented comprehensive smoke-free laws. South Dakota is among those states. There are still opportunities for greater protection from secondhand smoke. It is important to not just address combustible tobacco smoke, but rather all tobacco products, including e-cigarettes, which emit an aerosol. Also, people can make their homes and vehicles smoke-free. Policies can be adopted that make multi-unit housing smoke-free, and states and tribes can work toward making all public places and workplaces, including commercial and tribal smoke-free casinos. The process for commercial and tobacco casinos can have different challenges and different stakeholders. In 2015, the Cheyenne River Sioux Tribe became the first smoke-free reservation in South Dakota. The ordinance prohibited smoking and the use of e-cigarettes in all enclosed public buildings, including restaurants, bars, and gambling facilities. It prohibits smoking within 50 feet of entrances to public buildings and honors traditions while protecting health, culture, and future generations. Thank you to Ray O'Leary for her work with Missouri Breaks Research Industries Incorporated at the time of this accomplishment. Before I talk about the third strategy, access to cessation services, let me start with why cessation is so important. Smoking cessation has health benefits at any age, no matter how long or how much someone has smoked. Quitting smoking not only reduces the risk of premature death, and it can increase life expectancy by as much as a decade. And here you can see a timeline of how quitting smoking can trigger a series of changes in the body that continue for years, decreasing the risk of adverse health events or adverse health effects. For example, as you can see on this slide, just minutes after quitting smoking, the heart rate drops. After 1 to 2 years, the risk of heart attack drops sharply. And 20 years after quitting, the risk of cancers in the mouth, throat, voice box, and pancreas drops to close to that of someone who does not smoke. In addition, at 20 years post-quit, the added risk of cervical cancer drops by about half. And that's just highlighting a few of the changes. Access to comprehensive and barrier-free cessation services is the third strategy I want to highlight. Ensuring insurance coverage for evidence-based treatments for tobacco product use and dependence such as counseling and nicotine replacement therapies or medicine, is an important facilitator for access to cessation services. In addition, integrating tobacco screening and treatment into routine clinical care protocols can prompt providers to provide these services. And instituting systematic referral protocols to treatment extenders such as quit lines can help connect patients to free and readily available resources to help support them in quitting. Establishing these system level norms can help reduce disparities in terms of who is providing cessation treatment and support. To expand on how quit lines can be helpful, I'd like to show you this video clip. Take a listen.
When you call, we'll talk about the reasons you smoke, why you want to quit, and what can make quitting easier for you. Together, we'll find the tools that will help you the most.
I can help you find tools and ideas to give you the best chance of quitting smoking based on your own situation.
There are many different approaches to quitting smoking, and most people find that a combination of tools works best. For example, you can use texting programs, online tips and information, or mobile apps like QuitStart. Your coach can give you a list of other resources to help you quit. Nicotine replacement therapy, or NRT, which usually comes in the form of patches, gum, and lozenges, gives you a small controlled dose of nicotine. It can reduce withdrawal symptoms and cravings and has helped a lot of people when used as directed. You may be able to get a starter kit of NRT from your state quit line. Your doctor may also prescribe medications to help you quit smoking.
Medications, like nicotine replacement, can help with the physical part of addiction. Resources like online and mobile tools can help you handle cravings when you can't call a coach. And other tools, like your quit plan, can help you avoid triggers.
Just knowing that others had used these techniques to quit smoking really helped me. It told me these things actually work.
Ready for your own QuitLine success story? Call 1-800-QUIT now or visit cdc.gov/quit to get started.
Great. Next slide. The fourth strategy is hard-hitting media campaigns. We are in the golden age of mass media campaigns to educate the public about the dangers of tobacco product use. Currently, there are several national level media campaigns such as FDA's The Real Cost, the Truth Campaign, and CDC's Tips from a Former Smoker campaign. These campaigns all work together to target various topics and populations of interest. Mass reach health communication interventions are scientifically proven tools for preventing the initiation of tobacco use among young people, increasing cessation and the use of cessation services, and shaping social norms related to tobacco use and secondhand smoke exposure. However, effective mass reach health communication interventions can be very costly. CDC encourages the use of the TIPS campaign, which is currently running in every television market through September 2022. There are also special media purchases running in Indian country. For example, TIPS ads are running on Good Health TV in Indian health clinics. There are many other media tools that are cost efficient, like earned media you can gain by working with your local media like newspapers and digital media. Lastly, media campaign evaluations have shown that hard-hitting advertising that elicits negative emotions through graphic and personal portrayals of the health consequences of tobacco use is especially effective in motivating people who smoke to quit. Retailer-focused strategies can serve as an important complement to evidence-based strategies as part of a comprehensive approach to reduce tobacco-related disease and death, especially for those groups with the greatest burden of tobacco use and tobacco-related disease and death. To implement and enforce tobacco retailer environmental strategies, it is important to know which retailers are selling tobacco products. The retail environment is used heavily by the tobacco industry to promote and advertise its products. It is therefore also an essential environment for tobacco prevention and control strategies. Example strategies include product availability, prohibiting sales of the product or requiring minimum package sizes, pricing and price promotions. I've already mentioned taxes, but there are other strategies as well. Minimum floor pricing laws set a minimum price that tobacco products may be sold for. And advertising and display, point of sale marketing bans or restrictions. In South Dakota, there are gaps in the state's licensure policies. For instance, there is no retail licensure required, and therefore no penalties for youth purchases and the like, potentially cutting into gains made in cessation efforts. South Dakota could address challenges in youth initiation by addressing its lack of retail licensure. I now want to talk about regulation as a strategy to prevent and control commercial tobacco use. The Federal Smoking Prevention and Tobacco Control Act, signed into law in 2009, granted FDA the authority to regulate the manufacturing, distribution, and marketing of tobacco products. FDA does this by defining policy, issuing regulations, conducting research, educating Americans on regulated tobacco products, and decision-making on whether new products and health claims can be marketed. One example of a regulatory action is the FDA's April 2021 announcement that they are working toward issuing proposed product standards within the next year to ban menthol as a characterizing flavor in cigarettes and to ban all characterizing flavors, including menthol, in cigars. These actions are an important opportunity to achieve significant, meaningful public health gains and advance health equity. FDA expects to issue proposed rules for these two product standards in the coming months. At that point, the public will see the specifics of the proposed product standards and will have the opportunity to comment. In general, comments to proposed rule dockets may be helpful in determining what changes, if any, might be made from the proposed rule to the final rule. And the reference for that is FDA on track to take actions to address tobacco-related health disparities on the FDA website, depicted on the slide. Finally, I do want to note that in addition to FDA's announcement, we've seen continued progress as communities across the country have prohibited the sale of flavored tobacco products. Overall, we have seen over 120 communities prohibit the sale of flavored tobacco products and include menthol cigarettes in these prohibitions. Let's switch gears now and take a look at some recent accomplishments in South Dakota. I'm very excited. This is, of all the slides that I have presented, I'm very excited about this one. 2021 was a very productive year in tobacco prevention and cessation. Even through the ongoing COVID-19 pandemic forced changes to some activities, several successes were achieved. Here are a few to mention. In terms of cessation, over 200 South Dakota residents opted to utilize Kickstart kits, which provides at least 2 weeks of nicotine replacement therapy and a quick guide, which helps those wanting to quit smoking to be more successful by providing helpful hints and proven techniques for cessation. And your e-referral capabilities were increased, where many healthcare professionals there were 250 e-referrals that were received to the South Dakota Quit Line, so yay. In terms of mass health communications, South Dakota, together with every state in the National Tobacco Control Program that the Office of Smoking and Health funds, is addressing e-cigarette prevention. South Dakota was able to get 2 media campaigns in TV and radio, and they were conducted to feature new vape and cessation ads, one of which you'll see in just a moment, focusing on e-cigarettes and youth. In terms of prevention, with the focus on behavioral health facilities were very supportive in incorporating Quitline services into their treatment plan. One facility is serving as a pilot program for clients to receive Kickstart kits while currently in treatment. There were some, the Teens Against Tobacco Use held virtual trainings during 2001, serving over 200 and 60 youth to discuss prevention of tobacco use. And let's talk about secondhand smoke. South Dakota has a smoke-free law for workplaces, bars, and restaurants, but reports have surfaced regarding the use of e-cigarettes in these facilities while prohibited by law. Window clings and signage, more window clings and signage have been provided to help educate the public about these restrictions. And lastly, with South Dakota's work with Missouri Breaks Industries Research, they're working with as their local lead agency to increase tobacco prevention and control efforts among the American Indian population. The Find Your Power Toolkit helps provide technical assistance and education on how to prevent commercial tobacco use and promote cessation. So now we'll look at the video, the specific video on vaping and e-cigs among youth.
Some people think vaping is harmless. It's not. The nicotine in vape is highly addictive, same as tobacco. It weakens your immune system, increases heart rate and blood pressure. Some say vaping reduces stress. Nope. Vape causes mood swings, adds to stress and depression, even causes permanent brain damage to kids under 25. That's stressful. Nicotine addiction is no joke. Call the Quit line, 1-866-SD-QUITS. Be done.
Well done, South Dakota. You have done an amazing job with your work this year and in previous years. And I am just so honored to be able to be your cheerleader today. What keeps me inspired is that there are actionable steps that can be taken to advance health equity and reduce health disparities and commercial tobacco burden among South Dakota residents and specific populations. Let's remember what Oprah said and continue aiming for a smoke-free South Dakota. I know that I have presented quite a bit of information today, so let me recap for you the most important points. Cigarette smoking remains the leading cause of preventable disease, disability, and death in the United States. Progress has been made in reducing cigarette smoking nationally, but disparities across population groups and youth use of e-cigarettes are significant concerns. The tobacco product landscape continues to diversify to include new and emerging products, including electronic products. And lastly, we have evidence-based strategies that have been proven at the population level, but it is important that we continue to build the evidence for promising practices that have been implemented in communities and localities. It is critical that commercial tobacco control keep pace with the changing landscape and the inequities, and that inequities are addressed. Thank you for allowing me to be a part of this discussion today. You can see my contact information here. And lastly, thank you so much to my dog, Winston, for not barking during this entire presentation. Thank you. I think we have time for questions.
On your slide about the recovery from smoking, do you do anything you have with the lungs, but do you do anything with the brain? What impact can we share with folks on their brain?
So that would be of significant interest to me, especially with my background in neuropsychology. I have not seen a graphic concerning what the changes to the brain may be, but I will look and ask my colleagues back at the office if there's a similar graphic about brain recovery.
That would be awesome, because when we talk to youth about brain receptors and how nicotine is taking that spot, you know, the nicotine is replacing the dopamine, it resonates with them. You can see their little brains processing that. So it would be great to show something about that, because they're concerned about their brains.
Yes, that's a good point, and I'll research that further.
If you have any questions, feel free to put them in the chat. We do have a few that privately on the back end we got, so I'll read those to you.
Okay.
And can you tell us more about the upcoming Surgeon General's report?
So let's see, I mentioned it very early in my presentation that we have a upcoming Surgeon General's report on tobacco and disparities. My guess is that there'll be more information in there really about some of the disparities that I mentioned in the presentation, more about race and ethnicity, housing situations, really focusing on multi-unit housing, e-cigarette use and the flavors, and a lot of different types of disparities, social and economic. My guess is that it'll be to a larger extent, but based on the science that is coming out as well.
Wonderful. Let's see here. I don't know if you can answer this or not, but most flavors of e-cigarettes are now banned. When might we have a better sense of how that might impact youth usage?
Okay, so as science, as at the CDC, we're really based on science. So the only way that we would be able to tell, and that states would be able to tell, we would be able to tell through our national surveys, and you would be able to tell through your state surveys. So like say through your surveillance efforts, you have a state, you have state added questions to BRFSS. If you do a YTS that's state specific, or you would be able to tell through surveillance. That's the best way that I could tell. And that would be the only way CDC would be able to report on anything, is because we don't put anything out that's not based in science. So you would be able to do that on a state level as well. So maybe adding questions about wondering if people are still using flavored e-cigarettes, you might be able to do that. I think that's how states typically do it. If they really want to know they really want to ask specific questions of their community, they can add questions to their surveys, and that's how they would get the responses. And you can do that with middle school and high school students through some of your YTS surveys if you conduct those.
We've been asked by a couple people if we can get a copy of your slides.
Indeed.
So I said we were going to check with you, and we can send them out in the follow-up email if that's
Yeah, they can be
approved.
shared.
Okay. Let's see. Can you explain this slide a little bit more on acidic and alkaline in the products?
I wish that I could. In terms of nicotine salts, I wish that I was more, a toxicology or pharmacologic background, but that is not my bailiwick. But if you would like more information about that, I would be happy to share it at a later date. But I wish I could explain that more. What I just know that, in terms of making whatever the process is, they're making the nicotine more acceptable to the body and the person through the various pharmacological, ways that they're doing acidity and alkali and shifting it from acid to base.
I think we're going to look at doing the polls here.
Okay.
All right.
This might be the wrong poll.
Yes. One moment. I guess while we wait for that, I could ask you another question. Let's see. Where did that go? What may be contributing to disparities in quit attempts and successful cessation? It's It's a loaded question.
It is. It is. Because I have a non-CDC answer, and my CDC answer is there. We don't have the data to actually tell you, from the data. Like I said, CDC is driven by science, so whatever the science gives us, that's how we give your responses. But the Henraya response, I feel like, is in recent times we've been through major upheaval in our lives, and the human part of me feels like people are just not, people need a crutch, and people need something in their lives to help them deal with stress and help them deal with the life that we now live through this pandemic. And through, and people are not as apt, I would feel, to quit. Maybe they don't know as much about the campaigns, although tips is everywhere, and tips is everywhere. But maybe it's more about the locus of control within themselves, about whether they, feel like they can quit, feel like they want to quit. There are a lot of things that, I personally feel that, but I feel like it's more psychological than putting we have the knowledge, it's out there. If they want help, they can get help, they can ask the questions of their healthcare providers. Pharmacists now are being able to prescribe, NRT in some states. We're in the behavioral health facilities where some are now able to offer NRT in behavioral health facilities as well within the mental health and substance abuse population. So there's a wealth of information out there about quitting. I think it's about the process of pursuing it, if you ask me, and the time we just lived through and are continuing to live through, I don't think helps.
Wonderful, thank you. And it looks like the
Sure.
poll is ready this time.
Okay.
So we will get that up here. And feel free to take the polls, everyone.
So most of you all got the answer correct, with cigarette smoking being that answer. Okay. Question 2, true or false?
It's not showing question 2. Oh, there we go. Mine may just be a little behind.
So is this statement true or false? Being a current or former smoker can increase your risk of getting extremely ill from COVID-19. Yay. I said that during the presentation. That's great. So what is causing concerns for the youth population regarding tobacco use? Is it flavored cigarettes, resurgence of cigarette smoking, e-cigarette use, or there is no concern regarding youth and tobacco use?
Trick question. There should be like an A and B sort of choice.
Ready for the next one?
What was the answer?
Can you all see it? It's e-cigarette use. Majority of you answered.
I think we should give the folks that said flavored cigarettes like a part of that as an honorable mention.
But don't you think also regular cigarettes, because they're migrating away from the e-cigarettes to the regular smoking? So that was a trick question.
So true or false? Nicotine is dangerous to children. Is not dangerous to children. Nicotine is not dangerous to children. Excellent. What has been proposed recently to help reduce addiction and youth experimentation with smoking? Reviving the DARE initiative, banning menthol as a characterizing flavor, raising the legal purchasing age to 25, and banning the sale of cigar and cigar products in gas stations. Great job.
We have one more. Excuse me.
Which of the following is not a benefit of smoking cessation? Increased life expectancy, reduced risk of premature death, increased risk of heart attacks, decrease in coughing and shortness of breath.
I think the question must have closed or something before. I'm not able to answer it. I don't know if anyone else is.
It doesn't let you pick. Yeah, right to know.
I missed what the answer was to the one previous to.
Oh, it was the menthol one, Michelle. Menthol, banning menthol as a flavor.
Okay, that's what I thought the answer was. Thank you.
Okay, that was our last question.
All right. Are there any other questions for Dr. McGruder? Otherwise, we have some questions we might ask all of you, but I just want to give you the opportunity if you have any last minute questions.
I do. This is Tynell. So Henraya, with some of the data coming out and some stuff on your slides kind of brought it to like piqued my thoughts in my brain. With the data coming out of like mental health kind of being the leader in why kids are using, and I think it's probably always been the case, we just are more comfortable talking about it now and recognizing that that's what it is. Is there at the CDC level, is there talks or plans to partner with agencies that work with mental health so that, and then that be passed down to us as well?
So a part of the cooperative agreement that I'm working with is South Dakota. One of the population strategies is about behavioral health. And each recipient of these funds that we provide are able to look at substance abuse and behavioral health communities around tobacco use, and whether and however they wish to within this population. So it's a little early to figure out, each entity can pick whatever population they want to work with in terms of behavioral health. It is a priority for CDC, but it's still early in our funding period. We have a 5-year cooperative agreement with all the states in DC to see what particular recipients are looking at behavioral health in children, what particular populations are looking at behavioral health in other aspects of the population. So that data will be forthcoming to be able to present you more information about what's happening with behavioral health in kids and why the smoking rates within that subpopulation. But I did want to say that there's a commitment through the funding that each of our recipients are receiving for community-based disparities, as well as behavioral health and e-cigarettes.
Any other last minute questions?
She's a really impressive person.
If not, Dr. McGruder, thank you so much. I think we all
You're welcome.
learned quite a bit today. It's always amazing to just get an update of what's all going on and where things have, been and where they're going, and always just so fun to listen to. So appreciate everything that you provided us today and spending your morning with us.
My pleasure.
We will send out the slides since you said that was okay.
Yeah.
So everyone on today, we will get that sent out to you along with anything else that we need to include. But yeah, we will head into break. We're going to head into break a few minutes early. So, but please come back at 10:35 Central Time or 9:35 Mountain Time, depending on where you're at in the state. And we will see you back in a little bit. Thank you, everyone.